And then let me just share my screen. So 1 second. Right, can everyone see that? Yeah, is
Yeah, it's not on sharing mode in terms of as a slide.
that
That's it,
better?
perfect. Yeah.
Okay, perfect. Right, thank you so much for joining today. It's really great to see everyone, and this is very exciting because this is our first campaign for the start of the 4 that you'll be working with us on. So obviously, as you know, this is around bladder cancer, and we sent across the kind of in-depth toolkit at the end of last week, and there'll be an opportunity to ask any questions about that at the end of the session. I know my colleague Hector is on the call and she has gone off camera, but just to use this opportunity to say Hector has been the driving force behind this campaign and putting it all together and getting all of the information and clinicians and all of the media work in place. So huge thanks to Hector for getting us to this point. The point of this session today is to quickly run through a bit of the kind of clinical background to bladder cancer and the key signs and symptoms, some of the key messaging. We've also got an opportunity to discuss some of the campaign materials and hear from a colleague at the Royal Marsden who is the professional lead for physiotherapy. So they'll be talking about the role of kind of physical activity in relation to cancer. So Lucy is going to be kicking us off. As I said earlier, Lucy has a very, very long title, so I'll let her introduce herself. But she is one of our clinical directors here at RM Partners, but she has many other hats. So I will hand over to Lucy.
Thank you so much, Stephanie. And yeah, thank you again, ECTA, for all your hard work. And thank you for all joining us for this really important campaign and for all your support that you'll be giving us through the coming campaigns as well. So yeah, my name is Lucy, or Dr. Lucy Snedden. I am a GP in the Battersea area in Wandsworth. I'm here in my remit as RM Partners South West London Clinical Director for Primary Care, very wordy name. I also have another extended role in cancer in that I work in what's called a rapid diagnostic cancer clinic at Chelsea Westminster. So a GP that has an extended role in cancer. If we can move on to the first slide, that'd be great. Thanks, Stephanie. So yeah, what we wanted to just go through, it was a bit of a sort of a whistle stop tour about bladder cancer so that you can have a bit more awareness. I don't know people's level of knowledge and awareness of it already, so forgive me if some of it's very straightforward to you, but we just thought it would be good to kind of summarize what bladder cancer is, the reason that we're doing this campaign, and why it's important for us to be discussing this. So as it says, in the UK, we have 20,000 cases of bladder cancer each year, but it's still not one of the sort of most common cancers that people recognise. Now, our Cancer Alliance works across North West and South West London, so we cover a large area, both in terms of GP practices, patients, and also hospital trusts as well. And what we've decided is, in partnership with a charity called Action Bladder Cancer UK, we wanted to do a campaign to make people more aware of the symptoms and the signs of bladder cancer so that they can approach their healthcare professionals early. So the main focus of our campaign is based on people that may be at higher risk. So we're focusing on people that are over the age of 50, especially women, where women often find it harder to end up being diagnosed with bladder cancer because its symptoms are very similar to a number of other things that are not cancer related. We're also making sure that we're looking at it from a health inequalities perspective. So we've got to focus on people from lower socioeconomic state groups, because they are more likely to experience a late stage cancer diagnosis. And this has been seen in a number of different studies. And also, furthermore, we're also focusing on people in a Black and South Asian ethnic backgrounds who, again, are already at an increased risk of health inequalities. So that's the main focus of it. If we move on to the next slide, please, Stephanie. So in terms of bladder cancer, as mentioned, especially in women, the symptoms of bladder cancer are often overlooked because they mimic a number of other conditions which are not cancer. So specifically, the symptoms are often very similar to those which people might experience with urinary tract infections, which people might recognise the acronym UTIs. For example, getting blood in your urine is most commonly caused by urinary tract infection, but it can also be caused by bladder cancer, and we want to make sure people are aware of that. In women, there's a number of different gynecological issues that can cause it. Specifically, when women are postmenopausal, we will find that they will start passing urine more often or with more what we call urgency, so feeling that they need to go to the toilet more often. And we just need to make sure that people are aware that that can also be the sign of something more worrying, such as bladder cancer. Now, if we look at the information on the right-hand side, it shows how much of a difference it can make with bladder cancer in terms of what stage people are diagnosed with. Now, with staging, for those who may not be so familiar, in general, having a stage 1 is the early stage cancer, and stage 4 suggests that the cancer has spread much more widely. Now, looking at it, we do see that in women, the 1 year survival rates are poorer than men, which makes it even more important for this campaign to raise that awareness so that women can present to their primary care clinicians early to make sure that they are being investigated appropriately. Now, in terms of the stats, as it says, 80% of people diagnosed with stage 1 bladder cancer will survive their cancer for over 5 years, whereas the stark contrast to those who are diagnosed at stage 4, that percentage goes down to only about 10%. So it just shows that the earlier that the cancer is diagnosed, the more likely the treatment is to be successful and people's survival will increase. On to the next slide, please. So when we think about cancer, what we should always be thinking about is the risks and those people that we should be more aware of or more concerned about it. So the main risk of bladder cancer is smoking. Now, smoking is obviously a risk factor for a number of different conditions, including many cancers, some more obvious than others in terms of, people will often associate smoking with lung cancers or oral cancers, so cancers within the mouth and throat. But it is also a significant risk factor for bladder cancer. And about half of the bladder cancers that are diagnosed will be related to people's smoking status. Now, at RM Partners, we're always quite keen on making sure people are thinking about smoking in terms of tobacco consumption as a whole, because we do recognise that people will have exposure to tobacco in a number of different ways, whether that's smoking cigars, cigarettes, but also we have to think about things in terms of shisha pipes and hookah pipes and also normal pipes as well. And so smoking is obviously something that we're really focused on trying to reduce because it is a huge preventable factor in many cancers. Now, if someone has smoked versus someone who's never smoked in their life, that risk of cancer of the bladder specifically increases by 4. So it's 4 times higher, so a really significant difference. And the risk increases in the smoking cohort in those who smoke more heavily, or if they started smoking at a young age and continue to smoke for many years, and those who've just smoked for a long time as well. Now, people often don't really understand why smoking increases their risk of bladder cancer. But essentially what happens is when you smoke, the chemicals in the tobacco can get into your blood. And because of the way that these are released from our body, these go through the blood and then into the kidneys and then end up in the urine, which then is stored in the bladder before it's released. Now, because of the time that the urine might be in the bladder, these chemicals basically make contact with the lining, and those types of chemicals can cause bladder cancer. It mentions the specific names, aralamines, but it's not something that people will talk about commonly, but smoking is certainly the biggest risk factor. If we move on to the next slide for some more risks, other risk factors that might increase people's risk of having bladder cancer. So specific chemicals that people may be exposed to at work. Now, this risk may not be as high as it has been in the past because of more awareness of this, but it is still an increased risk in people. So particularly if people are working in things like the textile industry or handling oils or carbon, these people can have an increased risk to certain chemicals that can increase their risk as well. In terms of family history, if you've got a first degree relative, so whether that's your mother, father, your siblings, or your own children, if they have bladder cancer, then that does mean that you have a slightly higher risk of bladder cancer. So it's always important for people to be aware of their family history if possible. Other things that can increase the risk is if someone has had a cancer within their pelvic region in the past, and that can affect both men and women depending on the types of organs that were affected in the first instance. And if they've had then radiotherapy in order to treat this type of cancer, they may be at an increased risk of having a bladder cancer because of their treatment. So people would hopefully be made aware at the time of their radiotherapy and at the time that they end their treatment of symptoms be watching out for, including ones in terms of bladder cancer symptoms. And then one of the other key risk factors is being overweight or obese. And there's a number of different kind of bits of research that have suggested that people can be at an increased risk of getting bladder cancer if their weight is higher. And there's a number of different reasons why our weight or obesity can increase our risk of cancers, not just bladder cancer, but others. It can do a number of things. So we need the hormone called insulin to help us break down things in terms of carbohydrates and sugars. And if you are more overweight, you become more resistant to the insulin, and that's what can contribute towards an increased risk. It also, fat can be more active, so it can cause a higher degree of inflammation, and those inflammatory changes can increase the risk of cells changing, which is what causes cancer. So there's a number of different reasons why it's really important for people to be trying to keep their weight healthy and to try and keep themselves active to try and reduce the risk of this inflammation. It also is really important because when you are having, for example, cancer treatments, it's really important for you to be at your fittest as possible so that you can withstand any side effects. But I'll leave Siobhan to talk more about that as well. But there's, a number of different reasons why it's important for us to make sure that we're maintaining a healthy weight. In terms of the symptoms, and this is what we're really wanting the campaign to make people aware of, is what to really be looking out for and when to be going to your GP. So if you even have just one isolated episode of noticing some blood that you can see yourself in your wee or your pee, it's really important to speak to your doctor. They would need to make sure that it wasn't a urine infection, and if it was, they would obviously treat that appropriately, but they'd be wanting to make sure it's gone away. But blood in your pee is one of the most important ones. Now, urinary tract infections, so UTIs, if people keep getting urine infections that seem to keep coming back again and again, or that doesn't seem to go away, especially if you've had treatment, for example, antibiotics, that's another reason why we would want people to be going to see their GPs. Same if they're having any urinary symptoms that they can't work out. And again, these are similar to the symptoms that people would have with a urine infection. But if for example, you were having pain, whether that's burning or stinging when you're peeing, and there's no obvious reason for it, again, we would want you to be seeing your doctor. And again, if you find that you start needing to go to the toilet more often to pass urine, or you're needing to get to the toilet more quickly because you feel that you really suddenly need to go, that's another reason why it'd be important. Now, at the bottom, there's a couple of symptoms that are mentioned, which are more what we call non-specific, and this is the type of symptom I deal with in my cancer clinic that I do at Chelsea Westminster. But if somebody notices that they start losing weight and they're not intentionally trying to do so, or they're just having this unexplained tiredness that just makes them feel generally unwell, again, those are other things that we would want you to be seeing a clinician for. On to the next slide. So if you did have, for example, any of those symptoms and you decided to go and see someone at your GP practice, just wanted to just explain a few things that might be done. So what they will normally ask you to do, and what at minimum they should be asking you to do, is to do a urine sample so that we could test it. Now, if you've got visible blood, obviously that will be visible to us as well. But a lot of people will come in and they won't necessarily be able to see the blood, or when they do the urine sample, it might not be visible. But we do something called a dipstick test, where we look with a test, which is a little slide of paper, put it in the urine, and that will tell us if there's any hidden blood in it that you're not able to see. Now, they will also then be finding out about any symptoms that you've been having, including if you've been having any stinging or burning when you pee. And what they may also consider doing is arranging for a blood test. Now, if your blood test shows that you have a raised white cell count, and just for those who may not be aware, white cells are the types of blood cells that we have in our body that help to fight off infections and inflammation. So if we have a raised white cell count alongside any blood in your urine that you cannot necessarily see, that would be a reason for your GP to be referring you down an urgent suspected cancer referral. Or also if, for example, you had the stinging in your urine or the burning in your when you wee, and you had no so you had not hidden blood in your urine when they did a dipstick, again, that would warrant a referral to an urgent suspected cancer referral for bladder cancer. Now, if you have non-visible blood, so blood that you can't see with your eyes in your wee when the GP tests it or the clinician tests it, but you don't have any stinging or burning, and you don't have a raised white cell count, it's less likely that you'll have cancer, but your GP will still need to make sure that they are doing further investigations to try and work out why, especially if you're over the age of 60. If you're under 60, then normally what will happen is the GP will obviously make sure that they rule out things in terms of infections, but they will also need to consider whether they should do any other tests, such as things like ultrasound scans, and they'll often seek some advice from a specialist, whether that's a urologist or a nephrologist who's a kidney specialist. Now, what would be important is if you were to go to your doctor with any of the symptoms, it would be good for you to have the following information, but it's also important for the primary care clinician to be asking patients this proactively. Because of the risks, it would be good for them to know what your smoking status is, including if you have any significant history of passive smoking, i.e. someone close to you smoking in close proximity to you regularly. If you've got any family history of cancer, especially if you've got a family history of bladder cancer, it would be good to have your up-to-date weight and height so that we can work out your BMI to check if there's any risks from being overweight or obese. It's also good for them to be aware if you have had any cancer treatment before, specifically any radiotherapy in the pelvis, and also if your job seems to be involving any chemicals that may put you at higher risk. On to the next slide, please. So if you get referred down an urgent suspected cancer pathway, you'll go and see a specialist. In terms of the investigations that you'll normally have done, most often it will be something called a cystoscopy, which is a camera test where they look with a thin camera and they look in your urethra, which is the tube where the urine travels from your bladder to the outside. So with men, that's through their penis, their urethra, and in women, it's very close to where your vaginal opening is. So they'll do this cystoscopy and they'll be able to have a look inside your bladder to see if there's anything. And if they do see anything that looks concerning, they'll often take biopsies, which is when they take samples of the tissue that looks concerning. They may also do some forms of scans as well. And as I say, they'll often do things like an ultrasound scan of your bladder because that may be able to show any abnormality in the wall of the bladder. In terms of if you were to be diagnosed with bladder cancer, there's a few different treatment options. Now, when you are diagnosed at an earlier stage, you have more options available in terms of treatment, and you also have less invasive treatments or less sort of complicated treatments. So one of the common things that people will have done is something called a TURBT, which is transurethral resection of a bladder tumour, which is essentially using that cystoscopy, which is the small camera. They'll be able to kind of scrape off the areas that are concerning, and that's normally if your bladder cancer is not deeper and going into the wall of the bladder. It's more if it's on the surface of there. They can also give you some injections within your bladder called BCG injections. Those are the sort of typical types of treatments that people will get in an early stage. If you're found to have a more advanced cancer, there's a number of other treatments. So you may need chemotherapy, radiotherapy, immunotherapy, which is another type of medication that can be used for cancer treatments, or you may need a cystectomy. Now, that can be either partial or total, and a cystectomy is referring to the removal of part or all of the bladder. And if that was to be something that you had to have done, they would normally form what's called a urostomy tube, which is when they essentially make a tube that goes to the outside, which is connected to a bag, which is where your urine would collect, because you do still need to be able to pass urine to get rid of any waste products from the body. Patients would be regularly followed up by their specialists, and that would often involve regular cystoscopies to check if there's any recurrence of their bladder, or it would involve scans, and they would advise in terms of how often those are done and for how long for. And throughout all of this journey, they would be hoping, they would be trying to reduce your risk of it coming back. And so things like stopping smoking would be things that would be really important for them to be discussing with you and for you to be considering. If we can move to the next slide. So that's the end of my presentation. So just a whistle-stop tour on bladder cancer. We can take some questions at the end, but what I'll do now is I'm going to hand over to Siobhan to just discuss a bit more detail about physical activity and cancer. Thank you.
Thank you, and thank you for setting the scene around physical activity already as reducing the risk. So if we just start with a little bit on the language here, actually, because physical activity and exercise are often used as interchangeable terms, and they're not really, they're quite distinct from each other. So physical activity is any bodily movement that uses energy expenditure through skeletal muscles. So that can be doing a few stretches at your desk, getting up and moving around, getting off the bus one stop early. Whereas exercise tends to be, it's a type of physical activity, but it tends to be a specific type that is more structured, it's repetitive, and it's with sort of a clear purpose. So that might be going to do a gym session or an aerobics class or going for a run, for example. And it's important because in the research, some research will be around exercise and some will be around physical activity, but it's particularly important when talking to patients about physical activity, because if you have people who've maybe never exercised before, and maybe they associate exercise with some horrendous experiences at school, like cross country and cold gym halls and never being picked first for the team, exercise might not be something that people can really relate to. Whereas if you talk about physical activity and getting moving more and considering things like walking or, just dancing around your kitchen, things like that, that all of these activities count, that can really help people to start being more active. So physical activity is kind of widely recognised now as really having a key role throughout the cancer care continuum. So it has a role in cancer prevention, and that is specifically as well in bladder cancer. Bladder cancer is one of the 7 cancers that's been identified as being more physically active can reduce your risk. It can also help to reduce the side effects of cancer treatments. It can help promote recovery so that people get back to their previous levels of function more quickly. It can help to improve quality of life, and in some cancers, it can help to reduce the risk of recurrence. So there are numerous benefits to being physically active generally as well, outside of considering cancer. So things like reducing the risk of type 2 diabetes, cardiovascular disease, but also the kind of more immediate rewards. It can help to improve sleep, it can help to manage stress, it can help to improve quality of life. So the recommendations, and you can download this poster from the Department of Health website, is that people should be looking to do 150 minutes of activity per week. And that is at moderate intensity. So moderate intensity is where your heart rate goes up a bit, your breathing rate goes up a bit, you maybe feel a bit warm. So we often sort of think of it as maybe being a brisk walk. So rather than a kind of a slow walk, a brisk walk, if you were walking with a friend, you'd still be able to hold a conversation. And whereas vigorous activity would be more like you wouldn't be able to finish your sentence whilst you were running uphill, for example. If you are speaking to somebody who's more active generally and does more exercise, then it's 75 minutes a week. So this is the minimum really to be able to achieve some of the health benefits. But what's really important to say is that there is no minimum to get started with. So any activity is good and more is better. And those people who are very inactive actually have the most to gain by making small increases in their levels of activity. What sometimes gets a little bit overlooked, so the Department of Health put it right in the middle of the poster this time, was the importance of building strength. So as well as the cardiovascular physical activity that we just talked about, like walking, cycling, swimming, building strength is important as well. Now, again, people will often think of gym-based exercise, maybe twice a week. And if somebody likes going to the gym, that's great. But you can also do these things at home with home-based exercise as well, and like body weight resisted exercise. And there are resources out there to help people. And it's really important alongside this that people try to break up the time they spend being sedentary. So digital lifestyles these days really mean that we can do most things from our phone.
Take another one, which is already been.
Oh, sorry, I think someone might. Okay. Yeah, so it's breaking up sedentary time. So for a lot of people who maybe work from home these days, you're not getting that incidental physical activity of walking to the bus stop and walking to the tube and that kind of thing. So it's really important that people are conscious of breaking up periods of being sedentary. And for older adults, it's also recommended that incorporate some exercises that improve balance to help reduce the risk of falls. Okay, next slide. Thank you. And so this is the prehabilitation guidance, which some of you might have seen. This came out in 2018, and there's a new guidance coming out this year. So this has been renewed, and I think it's going to be published by the end of the year. So there's basically, and since this initial guidance was that there was a growing research base to show that supporting people in prehabilitation, so the point of diagnosis before they start their treatment and during their earliest treatments, helps to get people into the best possible position for having their treatment. So it's about improving their physical fitness, but also being emotionally ready for your treatment as well. And this is a combination. Prehabilitation isn't just physical activity or exercise, it's also nutrition, and it's also your psychological well-being as well. And what's been shown is that people who are more active during their treatment tend to have fewer side effects during their treatment, or that their side effects are less severe. And in particular, we see that with fatigue. So people who are exercising at moderate intensity tend to have less fatigue side effects than those who are less active. It can also help people to feel a bit more in control, because it's something that they can be working towards during their treatment, and it helps people to recover more quickly from their surgery. So we see reduced length of stay, reduced time spent on CCU. But the evidence specifically in bladder cancer is quite limited at the moment. Next slide. Thank you. So during treatment, we'll often get asked whether, very historically, people used to be told when you're starting chemo, oh, you need to rest, but that is just not the case anymore. So we know that if people are resting, then they're not going to be using their muscles get weaker, and then when they're ready to start moving again, they're not able to do as much as before. They lose quite a lot of their physical functioning. So it's generally safe to exercise during treatment, we know that, but sometimes there might be some things that there's some caveats with. So you might need to be careful in the first few weeks after surgery. You might have specific advice on not doing any heavy lifting, for example, for the first few weeks. But what's really important is that after those first few weeks have passed, people start gradually building themselves up again. It's important generally, not even just on treatment, that people don't just suddenly start doing intense exercise if they've never exercised before, because that's where the risks can come about. It's generally safe, but it's safe if people start low and gradually build up. And I give them the confidence to do that and the kind of permission that it's okay to start with a 10-minute walk. Regular activity can help to reduce the risk of blood clots, which are common after a cancer diagnosis, and it can help to then maintain your fitness, your strength, and maintain bone health during treatment. Now, it might be that people have to modify what they do during their treatment, and for some people maybe who do a very high level of exercise, they might even need to reduce it slightly on some weeks, especially if they're having chemotherapy. But it's quite that can be quite personalised what people need to do. It might be that there are some weeks that they do a bit less. And what we tend to advise is if you're having one of those days where it's hard to do too much, try and just reduce the time you spend being sedentary. Because even just doing a few sit stands from the chair, or walking around the house, or getting out in the garden, all of these things can help. Thank you. And then after treatment, exercise after treatment has been shown to reduce the risk of certain cancers coming back. And this evidence base is particularly in breast, colorectal, and prostate cancer. Some of you might have seen a few weeks ago, back in June, I think it was, the challenge paper was published, and it was all over the news. It hit the headlines that paper, which was 3 years structured exercise after colorectal cancer, showed that there was a reduced risk of recurrence in the group that participated in structured exercise. So that was a real breakthrough paper in terms of reducing the risk of cancer coming back. It can also help to manage some of the late effects of treatment. Fatigue, for example, can be quite a long-lasting effect, so exercise can be used to help to reduce that. And it can also help people to get back to their normal more quickly, help them get back to hobbies, work, family activities, and things that they enjoy. So sometimes physical activity is the way that you get back to doing those things you want to do, like being able to get onto the floor and play with the grandchildren, or get back to work. So this is a paper from the ACSM, the American College of Sports Medicine, and they released a consensus paper back in 2019. And this is where we have strong evidence to show that exercise can reduce cancer-related fatigue, as I've already mentioned, improve health-related quality of life, improve physical functioning, reduce anxiety and depression. And it mentions lymphedema here, which is associated more with breast cancer and gynae cancers when lymph nodes are removed, and you can end up with a swelling in the limb on the side, for example, where the nodes have been removed in breast cancer. And there used to be a fear that you could increase the risk of lymphedema, but what we actually know now is that being active and building yourself up gradually and getting back to a level of activity or exercise is actually beneficial, and it doesn't cause exacerbations in lymphedema. And there's moderate evidence around bone health and sleep. What was interesting with this paper is that when people are on treatment, what they found is that even rather than 150 minutes a week, even if people were managing 90 minutes a week, of a mixture of aerobic and strength exercise, they were able to have these benefits. So that's also reassuring, I think, when people are on treatment, and if 150 minutes feels too much to get to, that anything that we say some is good, more is better, but this evidence showed that 90 minutes actually helped to make those increases, those improvements. Next slide, please. Thank you. So what does the evidence say on bladder cancer? Well, it is one of the 7 cancers that the ACSM in that same consensus paper said that physical activity could reduce the risk of. And it's particularly this paper that's on this slide here was particularly around invasive bladder cancer. The protective association was actually in the people that did the most physical activity. So I think there is still quite a way to go to know how much physical activity people need to do to reduce their risk, and for how long, and for what bladder cancers in particular that it would reduce the risk of. So there's always more research obviously needed, but I think we can confidently say that being physically active is a good thing to help to reduce risk. The other thing in this study was that excessive sitting time also seemed to increase the risk. So that's where, again, it's a really good starting point when people are really sedentary, just to get them thinking about moving more just in their daily life pattern, just to try and reduce that time spent sitting. And then the evidence specifically for people post their bladder cancer treatment is that they were reporting a better quality of life if they were physically active. And we haven't got as much evidence around during treatment for bladder cancer as we do in some of the other cancers, but certainly for some of those treatments that were mentioned by Lucy, we know that physical activity can help with those treatments in general. So again, being physically active during treatment would be something that could be recommended to people who are having bladder cancer treatment. And what's interesting as well is that 1 in 3 bladder cancer patients reports they've not been doing any exercise within the last 30 days. And knowing that this, even starting with reducing the sedentary lifestyle, that could be a really good starting point, and then people can build on that to increase their physical activity. Thank you. So there's some advice here on places that you can signpost people for more advice around exercise and physical activity. So we want to encourage people to be as physically activity as possible, including during their treatment. And if they're new to exercise, people don't necessarily need to see a doctor first unless there's any underlying symptoms or concerns that they're worried about. But simply starting with a low intensity exercise program and gradually building up is a great way to start. There's an app called the Active 10, which people can download, which is just encouraging people to do a 10-minute walk a day. So there's lots of resources out there to help people start to build up. A couple of the things that are on here is there's a good resource from Macmillan on physical activity and cancer. There's also something called the Moving Medicine website, which helps clinicians to use motivational interviewing techniques. And they've got different conversation ideas in there, and also some infographics to share with patients. But you've got, like, if you've got a 1-minute conversation, how can you raise it? If you've got 5 minutes, how can you raise it? So it's that kind of brief intervention. And then places like the Maggie centres are great because they have so many different types of physical activity that there's usually something for everyone there, whether it's a Nordic walking group or a Pilates class or some yoga. And finally, 5K Your Way, Move Against Cancer, which I'm sure a lot of you may have heard of. It's part of Park Run. So some of the park runs across the country are part of 5K Your Way. And the last Saturday of every month, where it is a designated 5K Your Way park run, people affected by cancer come along either to volunteer, to walk it, to run it, to cheer people on. And so it's got that great sort of peer support feeling with it as well. And the thing with those park runs is they don't have to do the whole park run, they can walk part of it, they can just get involved or just go along to see other people. So this can really help on that last point about the encouragement to keep going or exercising with a group. Setting goals has been shown to be really helpful for people, and also sort of realistic expectations that they can build on all the time to just make it a sustainable, active lifestyle change. And the thing that people are most likely to stick with is the thing they enjoy. So if somebody really hates the gym, it's not the thing for them to choose. So exploring other options is really, really valuable. I think that might be my last slide. Yes, I'll hand back to Stephanie.
That's brilliant. Thank you so much, Lucy and Siobhan. Hopefully that's given you a really good overview of the kind of key signs and symptoms and a bit of background to bladder cancer, but also, as we talked about before, we're really trying to weave in the kind of prevention messaging to this, and physical activity is obviously huge, both in prevention and when living with cancer. So thank you very much for both of those presentations. What we're doing now is just going on a quick overview of the campaign resources. So I sent across the toolkit to you last week, which I'm hoping that you've had a chance to read through, but I just wanted to highlight some of the key parts of that. So as Lucy mentioned at the beginning of the webinar, so this campaign is running across all 14 of our boroughs in both Northwest and Southwest London. It's using a kind of multi-layered approach. So we're working on both social media, we're doing some really big kind of out-of-home mass marketing. And when we say that, we mean kind of big posters on bus shelters. We've got one tram stop in Addington. So hopefully over the kind of course of the month, you'll be out and about and you'll see some of these things in situ. Again, just to reconfirm who we're targeting with this campaign, and it doesn't mean that the events or the messaging that you send out has to be exclusively to these groups, but these are the priority areas of focus for the campaign, and this is very much based on the data that we have as a Cancer Alliance. So we're looking at people over the age of 50 who are particularly or may have a higher risk, and we're looking at women. And I think Lucy touched on symptoms being masked as UTIs, but what we actually saw when we looked through the data is that women were presenting up to 3 times at GPs with symptoms that could be bladder cancer, but they were being issued with antibiotics because of this kind of masking of symptoms. So actually women were then waiting 3 appointments for referral into diagnostics, whereas men weren't. So there are some real kind of differences or experience there that we're trying to address with this campaign. The other group that we're looking at is lower socioeconomic groups, and also Black and South Asian ethnic groups, because we know that there are already existing health inequalities there. As you know, the bladder campaign is running for the whole of September, so officially launches today and will be closing at the end of the month, and it's in conjunction with Action Bladder Cancer UK, their details are included at the end of the toolkit. So if you want any further information around bladder cancer, their website is excellent, so please do go have a look at that as well. Here we've got a logo that's saying bladder cancer, same symptoms, different story, and that is the kind of catchphrase for this campaign. It's also going to be the hashtag, so when we're putting anything out on social media, we'll be using that. So anything that you're sending out, please do use that phrase as well. It's all kind of written clearly in the toolkit as to how it should be formatted, but that kind of really is the catchphrase that we'd like you to be using as you're kind of out and about talking about this over the coming month. Here is just again a kind of image or example of what the assets looks like, and that kind of key messaging. So they're the ones that Lucy went through in detail, but these are kind of the top 4 symptoms that when you're having conversations with people, if you could refer back to these as your kind of checklist, that would be fantastic. The thinking behind the structure is it looks like a GP notepad. You're going through, you're ticking off symptoms as you go along. And then we will just look at some of the campaign assets here. So you have the whole suite of resources at your disposal. I've just picked two here, but these images here are actually some of our clinicians across Northwest and Southwest London. So it's a mix of some of our GP clinical leads at the Alliance, some clinical colleagues that we've worked with before, and an advanced nurse practitioner. So everyone was very excited when these were taken. They had to go to the television studios and have their photos done. But everyone who you see in this is completely committed to the campaign, and they are the faces and images that will be across social media. They will be on bus shelters. They will be out and about. Some of the other kind of really smart things that we're doing with the media agency is we're really targeting on specific platforms. So as we know, the target cohort is aged over 50 and they're women where are this demographic most likely to go. So we're using targeted ads on Pinterest, for example, because we know that that is a platform that they might target kind of more frequently. The other thing we're doing with some of our social media posts is having very targeted ads. So we've talked about areas of deprivation or those of lower socioeconomic areas. We will be specifically sending it to their Facebook, their Instagram. So in those areas, if you log on with it in that specific postcode, you will be hopefully seeing this ad. The other thing that we're doing, and Exeter again has been working really hard on this, is working with our primary care colleagues and also our pharmacy colleagues. So the toolkit that you received, it had the community toolkit on the front. They've received a version that is specifically for primary care clinicians. So kind of the other side of the conversation for them, what they're looking for, kind of top tips in diagnosing. And the same with our colleagues in pharmacies. They're also going to be handing out some of the resources. So as I mentioned to you, you will be sent posters and some of those kind of wallet cards, which has this messaging and some of the key information on pharmacies. We'll also be handing that out in across the kind of wider footprint. And I've talked about the kind of mass marketing that we've got going on across the RMP. And then here, when I send you the slides, you'll be able to look at this in a more interactive way, but this is just a very quick snapshot of where some of these ads are going to be placed. So these are next to key pharmacies and they're bus shelters that kind of tally with the routes. So I'll send you the link, which is on a fantastic website called Maply if you're not familiar with it, and you can really zoom in your local area and look and see where those ads are in place. And we are always happy to see people taking selfies with these when they're out and about. So if you feel so inclined, please do. I know Hector and I will be. And then here, this is just to reiterate what is at the back of your campaign toolkit. So all of the shareable assets are available on this kind of website. So the website address is same symptoms, different story. On that, if you go on, you can download all of the social media assets that you might like to use. They're done by borough-specific clinicians. So if you work in Wandsworth and you want the face of Wandsworth GP, you can download that asset. We've also got posters on there that you can use if you need more. You can request more wallet cards. There are translations available. So I know we spoke before about what the most commonly requested languages are. There are available posters in 11 different languages, I believe. And what we've also recently added to the campaign are voice notes. So in the same languages, we have some of our clinicians across the footprint, very short voice notes, maybe 1 to 2 minutes, talking about the real kind of key signs and symptoms about bladder cancer, and they are downloadable. So for those of you who have Telegram groups, WhatsApp groups, and you want to forward on a voice note, or maybe just play it at an event you're holding, those resources are there for you. Hopefully the content and the resources to hand are quite extensive, but if we've missed anything or anything else you'd like as part of this campaign, obviously it's a month long, so please do let us know and we will do our best to provide that. I am very conscious of time. We've got 2 minutes, and I don't know if anyone has any questions on any of the content. Are there any immediate hands?
Yes.
Oh, go on, Felix. Yep.
Yes. Three quick question. The first is about the symptoms. Some of them are quite similar to prostate cancer in males. So any quick method to distinguish them. The second is about the diagnosis. Any golden standard for the diagnosis, that is still need to have biopsy or any less invasive method for the diagnosis. The third is about the treatment. Any new, give some hope to the potential patient that any new drugs development in the bladder cancer, like the MAB or some other new drugs.
I'll come in on that. So the first question was with regards to symptoms and the similarity to prostate. That's a very, very good question. So absolutely is the case. Now, what we would be expecting the primary care clinicians seeing patients to do would be to be doing, for example, the urine dipstick. Now, if that urine dipstick looks like it shows any blood or shows any signs of infection, they would often send off to see if any bacteria grows. But what they would also be wanting to consider is in men, especially men over the age of 50 or 60, they would be thinking about whether there would be any benefit from doing a PSA blood test, which is a blood test for prostate cancer. Now, they have to be careful to make sure that a patient doesn't have a urine infection, because that can artificially increase the PSA. So they would be needing to do those things in conjunction. And what would also be relevant is, like we mentioned, it would be good for patients or the GPs to proactively be asking about family history of relevant cancers, such as bladder cancer. Absolutely, it would be relevant for people to be aware about prostate cancer as well. So there would be a few different things they would do. But as I say, if, for example, they had these urinary symptoms, there was no signs of infection, there was no blood in the urine, and they didn't have any other worrying symptoms from a bladder cancer point of view, that's absolutely where the likes of a PSA blood test would be useful. Your second question, I didn't quite understand. It was to do with the diagnosis, was it, Felix?
Yes, diagnosis, golden standard, or any
Yeah.
biopsy or less invasive method.
So it would generally be, as I say, using the cystoscopy, which is the flexible tube with the camera, and because that would let them directly see it, and they would then be able to take samples. Now, you can have a radiological diagnosis of cancer, and where it's just based on the imaging alone, but that tends to be in patients where they're not really thinking treatment's going to be appropriate for whatever reason. So generally, they do need to find out the type, and the way of doing that would be with the biopsies, and that's how they would take them, would be using the cystoscopy. And then your third question, forgive me, I've forgotten it now.
New
It was
drugs,
about new treatments.
like MAP, something like that.
So in all honesty, as a GP by trade, it's not my area of expertise at all. So I wouldn't be the right person to answer on that. But medicine, as always, continues to evolve. There's certainly nothing in the pipeline that I'm aware of at the moment. But as I say, they are using things such as immunotherapy alongside chemotherapy, radiotherapy, etc. And obviously there will potentially be trials that will be available to people if they are eligible for them at the point of treatment, but that would be from the specialists themselves. All right,
Okay,
hopefully that answers it sufficiently. Thanks.
Thank you.
Great, thank you, Lucy and Felix. If everyone could stay on for another 5 minutes, I'd be very grateful, just because we've been joined, last minute addition to the webinar agenda, but we've got Kate White, who's from Superhighways. So hopefully some of you remember that name. They're the organisation that delivered the digital training earlier in the year. And so you met Sorrel before, who delivered the session, but Kate works at Superhighways and will be leading on some of the NHS app sessions that we talked about before. And if you could all hold on, she can just talk through what that offer might look like over the coming months. So whilst not specifically related to bladder cancer, what this is it's coming out to your groups, your communities, it's supporting with registration in the NHS app, it's looking at issues around digital inclusion, any of the resources that might be available. So if you could hang on again for another maybe 2 or 3 minutes, and I'll just hand over to Kate quickly to talk you through that.
Hi everybody. Yes, you've met my colleagues Sorrel and Mahira. We've been asked to build into this support programme some opportunities for support around the NHS app, and that's raising awareness of the full range of functionality, but also recognising that sometimes there are barriers to people using it, and that could be practical barriers to do with smartphones. It could be that people don't have email addresses or have multiple email addresses and have potentially registered for the app with one and are no longer using that. So we know sometimes there are these kind of practical barriers that get in the way. So what we offered to do was run some in-person sessions, and we can customize these to each of your organizations. So run something that maybe fits with some activities that you do already. So you might be running sessions and we come along for an hour. and run something on the NHS app. If in-person isn't going to work, then there is an option to discuss doing something online. And we'll have a look at the NHS app, but also there are a range of other NHS apps like Get You Better on the screen that helps people manage long-term health conditions, and a range of other ones. You've probably heard of some of these. Active 10 is one that I use. So we'll kind of raise awareness of some of these other apps that can help members of your community maybe reach health and fitness goals that they want to set for themselves. So yeah, a session that can raise awareness of what's available, but also have a look at some of those tech barriers. We also know that there might be some other digital inclusion initiatives that run in your area. So we'll also look at linking you up to some of those if that's something of interest, if digital inclusion within your communities is something that you've identified and is getting in the way of somebody accessing health services and information that will be useful to them. This slide is just them showing that one of the, you can access this via the NHS website actually, but it's also built into the NHS app. So that symptoms A to Z is a really useful feature for people to know about. They can look at that on the NHS app on their phone and search for symptoms and find out what potentially to do next. So I think that's all, Stephanie. Stephanie shared with me, so I'm Kate. Stephanie shared with me your contact details. We're offering this session between now and February, but we're quite keen to get some of those sessions booked in over the next couple of months. So I'm going to be messaging you. I'll send you an email, but also we'll use the WhatsApp group that's been set up so that just as a reminder. So I'll be in touch, and then you can get back to me and we can fix a date for that to happen.
Brilliant. Thank you, Kate. Right, thank you to Lucy and Siobhan for their clinical expertise and going through all things bladder cancer related and physical activity. I'm hoping that's been really informative for you all. I've seen a couple of the comments in the chat, so we'll be sending across the recording to you. So if you want to forward on to anyone within your organisation, we'll send across another copy of the toolkit. The website to download all the assets should be live later today, and I know there have been some asks for some of the resources that Siobhan mentioned as well, so we'll send across links and some of the downloadable posters there. A last plea from me, if you all your social media activity, if you could tag us and use the hashtag, that would be amazing. Again, all the details are in the slide deck, so I'll send them across to you. But thank you so much for your support with this. We really appreciate it. We know that your links to communities and all the work that's happening on the ground is absolutely integral to making this happen. And if you have any questions or any asks whatsoever throughout the course of the campaign, please just drop me an email. But thank you all very much for joining.
Thank you.
Thank you.
Cheers.
Thank you.
Bye.
Bye.